definitely teriflunomide is considered now as a very good first-line agent in relapsing remitting form of MS. Why? Because we have clinical trials, phase 3 studies with consistent efficacy in relapsing remitting MS, not only with a decrease of the relapse rate versus placebo, but also decrease the risk of sustained disability progression scored by EDSS. The two trials are really consistent. Also, the tolerability is really excellent. We have very good safety data because in the program of teriflunomide, we have not only the pivotal trials, but now we have data more than 8 or even 9 or even 10 years follow-up of the phase 2 and also the phase 3 pivotal trials. So telling that really we have no specific signals concerning an increased risk of infections, no opportunistic infections, no data suggesting an increased risk of malignancies, so which is excellent for the long term to treat MS patients. And also, maybe we have data concerning brain atrophy, because now, as you probably know, the best predictor in MS for the long term is cognitive functions and brain atrophy. You know, brain atrophy is really a driver of the long-term disability progression 10 or 15 years later. So maybe a good drug not only decrease the relapse rate and the risk of disability progression, but also need to decrease the rate of atrophy, and which is reached with a drug like teriflunomide, you know. Maybe teriflunomide is really a good drug as a first line, mainly for mild to moderate relapsing remitting MS. However, teriflunomide probably not a good choice for two categories of patients. First, very severe, very active relapsing remitting MS with high number of relapse, high number of T2 or gadolinium positive lesions. And the second category we need to avoid teriflunomide is maybe a woman who want to be pregnant in the next year, for example, short term. Because as you know, in the literature, in animal models, we have data suggesting that maybe could have some degree of teratogenicity of teriflunomide. But with the exception of the two categories, maybe really I think that teriflunomide could be a very good choice in relapsing remitting MS. The effect of teriflunomide in brain volume. You're perfectly right. I think it's definitely a target we need to achieve today with the drug in MS. Why? Because in the data we have large cohorts of patients, for example, the two main predictors of the long-term disability progression after 10 or 15 or 20 years are first, cognitive disturbances, early cognitive dysfunctions, and 2, brain volume loss, so brain atrophy. And so, as a consequence, a good drug needs also to control these two factors, you know, cognitive functions and brain volume. And with teriflunomide, in the pivotal trials TEMSO, we have indeed a reduction of brain volume loss versus placebo, roughly during the first year, about 37% reduction versus placebo of brain volume loss, and during the second year about 30 or 31% reduction of brain volume, which is good. Of course, probably a moderate impact, but it's difficult to do better with any drugs today. So maybe in the panel of effects we want to have with a drug in MS, we need also to include now a reduction of brain volume loss.